Good evening, Endo Summit Live, and welcome to the conclusion of now our sixth Endo Summit Live season. We have two amazing surgeons joining us and welcoming them to the Endo Summit family for the first time. From Tampa, we have Dr. Imad Mikhail. Dr. Mikhail, can you introduce yourself?
Thank you very much, Sally, for having me. My name is Imad Mikhail. I am associate professor at University of South Florida. I'm a chief of gynecology at Tampa General Hospital, and I am the medical director for the Endometriosis Center of Excellence for Complex Care.
Excellent. And joining us from New York is Dr. Mamta Mamik. Dr. Mamta, can you introduce yourself?
Yes, hi, my name is Mamta Mamek. I am an assistant professor at Albert Einstein College of Medicine, and I'm a urogynecologist and a neuropelviologist that will be shortly joining SC International as well. Thank you.
Excellent. So, Dr. McHale comes to us by patient recommendation, by the way. I have a very good friend, and he did her surgery, and she said that I can't do any more endometriosis summits without him. So, I am so happy to have
Yay.
you here. Dr. McHale, do you want to start your presentation?
Yes, definitely. Let me start to share my screen. Please let me know if you can see it.
We got it.
Yes,
Great. So again, thank you, Sally, for having me. This is a privilege to be with you guys and share the podium with Dr. Mamek. I'm gonna be talking really briefly about post-hysterectomy deep endometriosis. Those are unique cases that patient presents with deep disease that can affect many different organs. Most commonly, vaginal, urinary bladder, and sometimes bowel endometriosis. And this is my conflict of interest, not it pertains to this presentation. The objective is to go over kind of post-hysterectomy, a deep endometriosis, how to plan, how to diagnose, and what to tell the patient. Vaginal deep endometriosis is a rare condition. We don't have a true incidence of the disease. The most important thing to know is that it can present postmenopausal, and also it can present sometimes few months to long time after hysterectomy. The only literature that we have is kind of just case reports. We don't have true studies that kind of look at the incidence and the outcomes for vaginal endometriosis, but all we know comes from case reports. Um, we don't exactly know the etiology. Some people have theories, including transfer of cells to the cuff during removal of the uterus through the vaginal cuff. Some other things about, implanting of endometriotic cells. I personally believe that it is pre-hysterectomy, deep vaginal involvement that has been not recognized and not treated and thus persists after hysterectomy. One of the things that is interesting is that this disease can present in the form of malignancy. So this is postmenopausal patient had 30 years after hysterectomy, and the biopsy was not conclusive. And then when they took her back and did the surgery, it proved to be deep vaginal endometriosis. Malignant transformation can happen, although very, very rare. We have case report regarding adenocarcinomas, endometrial stromal tumors, and even endometrial hyperplasia. The most common presentation of post-hysterectomy vaginal endometriosis is post-hysterectomy vaginal bleeding. We kind of, it's a common knowledge that if the patient undergoes a hysterectomy, the patient is not expected to have any vaginal bleeding after that. Very rarely, some patients, if they have underwent supracervical hysterectomy, the endocervical canal can cause a little bit of, kind of sporadic spotting here and there. But for total hysterectomy, there should not be any a vaginal bleeding after the surgery, after the healing period. But those patients present with post-hysterectomy vaginal bleeding, either cyclic or post-coital, also pelvic pain and dyspareunia. People use, transvaginal ultrasound or MRI. I believe that MRI is superior in deep vaginal endometriosis, but sometimes ultrasound also can be beneficial. As you see, they are very comparable regarding their sensitivity. The most important thing is that we always talk about that experience matters for surgeons. The more the surgeons are experienced, the more they can deal with complex disease. But this is actually also important to recognize that actually scanning patients doing MRIs is experience dependent. So, if you have a radiologist who never seen deep vaginal endometriosis, they probably will not recognize it on imaging. And as you can see, this is a study that showed that there is a different positive predictive value according to the reader years of experience. The most common things to know about vaginal deep endometriosis is the size, if there is bowel involved, and if there is ureteric involvement. Um, Actually, some people went really far in trying to treat a vaginal endometriosis. Actually, this is a case study. The patient had very, very severe uncontrolled bleeding, and actually they ended up, providing the patient with radiation therapy. Again, this is not the treatment of choice, but I'm saying that people can go sometimes in extreme measures to control this disease. Now I'm going to jump to bladder endometriosis, which also can happen post-hysterectomy. Patients um, usually present with either hematuria, like blood in urination, or present with frequent UTIs, or present with a bladder mass. It involves usually the muscle of the urinary bladder, which is called the detrusor muscle. This is very different from the lesions that are superficial peritoneal disease just on the bladder area, not invading the bladder muscle. Again, the bladder is the most common organ to be affected by deep endometriosis, up to 80% of the cases. Luckily, most of the bladder deep endo happens in the base of the bladder. And as you can see, this area is the lucky part is not involving the trigone, although sometimes the deep endo affects the trigone. The trigone is a very sensitive area in the bladder anatomy, just because where the ureteric orifices come together and come to open inside the bladder. So luckily it is in the base. It is the most common site of deep bladder endometriosis. And again, regarding the etiology, it is very, very rare that this happens after hysterectomy. Most probably, there was bladder deep endometriosis that was not recognized, not diagnosed, left over, and the patient presents later after the hysterectomy is done with bladder endometriosis. This actually reminds me about the main concept is that endometriosis is an extra uterine disease. So doing hysterectomy and leaving deep endo behind is not helpful. Again, the clinical representation are usually non-specific presentation, recurrent UTIs or so, sometimes cyclic hematuria in a kind of quarter of the patients. The most common way to treat bladder deep endometriosis is to do partial cystectomy, removing piece of the bladder wall that is being affected with the disease. You know, technicalities regarding what suture to use. There's no kind of standard of care. Everybody, according to their experience, they use different type of suturing material, but almost everyone leave a catheter inside the bladder. But the problem is that again, there is no specific guidelines about how long people need the catheter after a partial cystectomy. Again, the most important things to kind of be aware is that endometriosis is commonly affecting extrauterine structures. Hysterectomy alone does not treat endometriosis. If you leave vaginal disease or bladder disease or bowel disease, um, you're not treating the disease that the patient is suffering from. One other point I want to kind of mention about post-hysterectomy disease is ovarian remnant. So ovarian remnant basically it is the presence of a functional ovary after unilateral or bilateral oophorectomy. So the patient comes in and saying, you know what, I had surgery before, I had hysterectomy, for example, and the surgeon removed my like whatever right or left ovary, but they present with pain on the same side that the ovary is removed. And you kind of wonder why the uterus is removed, the ovary is removed, why there is pain. Of course, this has to be kind of studied very well, and kind of the question has to arise: is this a deep endo or even superficial endo that is left from the surgery or recurred after surgery, or there's actually ovarian remnant? Again, ovarian remnant is a unique, rare condition, but we see it all the time with endometriosis patients. It is usually unintentional, incomplete dissection and removal of the ovary. The risk factors, the biggest one is endometriosis. Of course, pelvic inflammatory disease is another risk factors. Multiple previous abdominal surgery that makes really significant adhesions and make surgeons have difficult time recognizing anatomy and recognizing ovarian tissue. All this leads to ovarian remnant syndrome. Of course, the history, the physical examination, again, ultrasounds are great and MRI are great in diagnosing ovarian remnant. Usually it is so easy. Patient says, oh, I had my right ovary out. You did imaging, you find a right ovary. You kind of know that this is ovarian remnant syndrome. Sometimes it is so small that you cannot see it, and in those cases, I usually hyperstimulate the ovary to make it bigger, to be able to actually see the exact lesion, exact remnant, and to completely excise it. Residual ovary is different. Residual ovary is just ovary that is left and is not removed with the hysterectomy. Very different from ovarian remnant, which is actually an ovary that someone had uh, to remove in the past, but there is remnant tissue. Usually, excision of ovarian remnant is associated with a lot of surgery to be able to safely remove it. Most of the time, dissections, extensive dissections of the bowel, of the ureter, of the bladder, all of this are commonly performed to be able to safely remove the ovarian remnant. Again, one other big concept I want to kind of talk about is the difference between ovarian remnant and retroperitonealized ovary. Retroperitonealized ovary is a disease where the ovary is not removed, but yet the ovary is deeply go underneath the level of the peritoneum. Usually, this happens in diseases where there's a lot of dissection and the ovary slips underneath the peritoneum, and then the peritoneum covers above the ovary and it's so hard to find. Another area that kind of also we see after hysterectomy is parametrial endometriosis, and this I think this is the hardest a deep endo after hysterectomy that you can find. It can be affecting the ureters or affecting the deep kind of lateral parametrial where the sacral roots are. Ureteric endometriosis, the problem with it is that it is clinically silent in a lot of patients. So there is a lot of patient that presents with complete loss of renal function with no pain. And the ureter is completely obstructed on that side, and the patient develops complete failure of function on that side. Um, when you have a small stone, very small stone tries to obstruct the ureter, the patient presents with pain. Pain here is protective because it makes everybody alerted that there is something causing obstruction. But in ureteric endo, the obstruction is so subtle and so slow over a very long time, and hence there is no pain, and hence there is silent loss of function of the kidney. Ureteric endometriosis, most of the time is extrinsic, coming from outside the ureter. Sometimes it's deeply invade the muscularis propria and the ureteric lumen. The left side is kind of more common. The distal ureter around the uterocircular ligament is the most common site. What is the goals? What are we trying to achieve if a patient has a ureteric endometriosis pre or even post hysterectomy? The number one is to relieve the obstruction because you cannot sit on a hydroureter with deep endo. If there is the hydroureter, you act fast. If you cannot do the surgery right away, you just protect the kidney by even putting a stent inside the ureter or a nephrostomy tube, something to preserve the renal function of the patient. Um, um, the other thing is that um, deep lateral pelvic endometriosis. This is kind of, I believe it is the hardest location of deep endometriosis, and it goes so lateral into the sacral roots where the risk and the complexity of surgery is high. Meticulous dissection is important in cases if you treat deep endometriosis or treat a post-hysterectomy ovarian remnant, because those are really cases where there is a lot of scar tissue that causes the increased risk during the surgery. And thank you so very much for the opportunity, and I'm happy to take any questions or we can discuss at the end if you want, Sally.
That was an excellent, excellent presentation. We're gonna go ahead and let Dr. Mamta give hers, and then we will have a discussion after. You hit like just so many good highlights. You know, I do all this work with the AUA, and I kind of want to put you in my pocket and take you with me when I go there because I've been kind of preaching all that there. Anyway, okay, let's take it away, Dr. Mamta.
Thank you. Thank you so much for giving me this opportunity.
You used my slide.
You did so much, you made so much effort. I thought the logo was amazing. So let me just see how I can do the slideshow. There we go. Is that better? Can you see it?
That is excellent.
Thank you. Okay, so I'm going to end this session with a series of sessions that Sally had put together so beautifully with all the speakers, and because March was Endometriosis Awareness Month, again highlighting that on a very neglected topic, I would say, which is postmenopausal endometriosis. So endometriosis is already neglected, and then on top of that, there's the postmenopausal endometriosis, which is like really badly neglected. So I wanted to highlight that a little bit and add on. So this is rare. It's rare probably because it's underreported, to be honest. But in a lot of case series, it's about 2 to 5%, and they think it's usually due to a side effect of hormonal therapy, and maybe most likely related to unopposed estrogen use. Now, there is a possibility that there may be endometriosis, there may be a possibility that it's a malignancy, or there may be a possibility that it's both. And I'll go into that a little bit in detail later on. So, what are the risk factors for this? There is low parity, infertility, late childbearing, and oral contraceptive use is protective, but this is sometimes associated with it as well. So the good news and the bad news, I would say, is that most of the times this is found in the ovaries. Almost 79% of the cases are noted to be ovarian in origin as far as endometriosis. What are the theories? So it appears that even though there's menopause, right, there are these lesions that remain, as Dr. Mikhail was talking about, that these are not completely resected, or there seems to be no attention paid to these lesions, they can remain active under the right circumstances and demonstrate activity that proliferates them, and they have an intact hormonal responsiveness as far as the lesions, even though the patients may be postmenopausal. They still continue to have all the enzymes that are required for estrogen synthesis. So there's a combination of, it could be a recurrence, it could be a persistence, or there's a possibility that actually it's a de novo, meaning it's a new disease that's occurring in patients. So the reactivation theory states that, basically it's the same estrogen progesterone receptor. So even though there was a negative laparoscopy, sometimes the lesions are there. And these patients, especially those patients that have had a hysterectomy, as Dr. McCall mentioned, at an early age because of endometriosis, or they had management of unexplained infertility, these patients are at risk of this possibility of reactivation. De novo is when there's a genetic predisposition, which I'll go into later. There's a resistance to progesterone potentially in these patients, and there's a lack of cell death. So there's a lack of apoptosis. So the cells continue to work and they continue to overexpress these genes that converts androgens to estradiol, right? And then there's a local production of prostaglandins, and that causes inflammation and the estrogen synthesis to go up, and that again creates these lesions to flare up. What is the role of hormone replacement therapy? Well, of course, if there is unopposed estrogen replacement, that'll stimulate these lesions, right? This is more common in patients who've had a hysterectomy, because the thought is that, oh, they've had a hysterectomy, so we can give them unopposed estrogen. But no, please be wary of doing that, because this may actually cause flares or an activation of these lesions in these patients. Phytoestrogens, patients who are breast cancer survivors who use tamoxifen, all these patients who have these kind of endometriosis in addition will have a likelihood of recurrence. And estrogen only or progesterone only hormone replacement therapy has been also shown to increase the risk of malignant transformation in these patients. So that's another thing to think about. Again, the complex mechanisms are involved, but all I would say is emphasize that if it's unopposed estrogen in endometriosis patients, please be wary of that. How do these patients present? They have very non-specific symptoms. They may have pelvic pain, they may have a mass, they may have intestinal symptoms, they may have dyspareunia and pelvic pain, which are also associated, unfortunately, with menopause, right? So there's this complex interaction in endometriosis patients one has to be wary of and try to distinguish and discern the symptoms for what it is. There's, of course, nothing menstrual related because they're postmenopausal, but nonetheless, these symptoms need to be explored. And radiologically, typically they're the classic findings, that could be like a classic endometrioma, which has ground glass lesions. But then you have in menopausal patients some atypical appearances of ultrasound, which warrant further investigation, which have like internal septa, fluid levels, blood clots, hypoechoic content, and polypoid appearances. So these are something to be wary of. These don't necessarily indicate a malignancy, but they may be atypical endometriosis, which is more common in postmenopausal patients. So this is an example of what is polypoid endometriosis, which shows a high Doppler flow on the left side. This is a T2 weighted image on the right side, which shows this polypoid with small cysts here, but this is an atypical polypoid endometrioma. Now, compared to the premenopausal and postmenopausal patients, there's a lot of fibrous changes in postmenopausal patients, fibrotic nodules, and marked adhesions in postmenopausal patients. The uterus is, of course, postmenopausal, so there's reduced volume and thinned endometrium. So that is something to bear in mind. Now, there's also an association with cancer that I briefly alluded to. These two types of cancers, clear cell cancer and endometrioid adenocarcinoma, comprise 90% of the ovarian cancer that are associated with endometriomas. Now, if there is a malignant transformation, there is solid component, there is loss of T2 shading and more diluted fluid from the endovaginal ultrasound as well. So this is the solid component here. So this warrants more further investigation with an MRI. So what are the risk factors? The atypical endometriosis is a risk factor. There are genetic mutations. These are the hepatocyte nuclear factor, NFP1B, oxidative stress, chronic inflammation, exposure to any form of steroid hormones, which I mentioned earlier, estrogen, as well as progesterone-only hormone replacement therapy, and genetic defects, mutation in PTEN and TP53. Now, the perimenopausal age presents a very delicate time where there is more malignant transformation between the ages of 45 to 49. So at this stage, one has to be careful of ensuring that one investigates the endometriomas a little bit more thoroughly. These patients are also at risk of other malignancies like breast cancer as well as hematopoietic malignancies. So tamoxifen, which I had mentioned, any large-sized endometriomas, one has to be careful and cautious and evaluate further for a malignancy. The good news is that the malignancies that are associated with endometriomas, they have a more favorable prognosis as well as a higher survival rate. So that's the good news. So the treatments one could observe, of course, but this is a very, very cautious and regular checkups. But mostly the recommendation is a definitive management with surgical, and this is the favored approach, surgical resection. Medical management is less favored, and I'll explain why in just a moment. Surgical management is shown in various studies to alleviate pain and avoid malignant transformation. This includes removal of uterus, ovaries, fallopian tubes, and all the endometriotic lesions. So this has to be a thorough evaluation for all of these lesions and remove them for both treatment purposes as well as for pathology purposes. So the medical management includes insertion of an intrauterine device, which again is a less studied modality of treatment in postmenopausal patients because this is a treatment that is used in the reproductive ages. But it has shown to reduce the severity of lesions and reduce the size of the rectovaginal lesions. There's also the option of aromatase inhibitors, but this has again been not studied as much in the postmenopausal patients, but it may reduce the lesion size and alleviate symptoms as well. So one thing to be mindful about when treating patients who are undergoing menopause and who have endometriosis is that this requires a thorough evaluation of the patient, and a combination formulation is preferred or tibolone so that they don't have a recurrence of their endometriosis and also a progression of their endometriosis to malignancy later on. So I just want to go into the lack of research a little bit here and maybe the philosophies. You know, there's a type of injustice that one of the philosophers that I read about, Miranda Fricker, talks about. It's called epistemic injustice. And in that, she talks about a testimonial injustice and hermeneutical injustice. What a testimonial injustice is, there's prejudice when a listener assigns a lower level of credibility to what a patient or a speaker is saying. So healthcare patients, for example, in patients that are menopausal, may not believe their symptoms because of their age or their gender or their biological stage in life. And hermeneutical injustice is when the society expects certain expectations that, oh, in postmenopause, everything is sort of shut down. We don't expect you to have anything symptomatically as such in this. So there's a collective gap in the interpretation, and it leaves the postmenopausal patients at a disadvantage in explaining their symptoms, in explaining their social experiences, in explaining what treatments they can seek. So this is something to be mindful about. So it is a challenging dynamic, and we as clinicians have the primary responsibility of ensuring that we don't propagate stereotypes. You know, we need to inform medical professionals that, you know, there's a possibility that this could exist, and we shouldn't just look at age, that, you know, when patients report some symptoms, they warrants an investigation. So we also need to then propagate this among society at large which means we have to do more research and encourage more knowledge in patients that are aging in general, and avoid ageism and sexism, and not concentrate our research to just reproductive age women. So this is something that I just wanted to bring up at the very end. So I wanted to thank you for your attention, and I appreciate any questions you may have.
That was a great presentation. You want to go ahead and stop your screen share?
Yes, I'll do that.
That's the first time I've seen the slides in action. It's very exciting.
Thank you.
It'll be interesting. You should bring your slides with you this weekend.
Okay.
But
I'm
it's
ready.
interesting because we have a sort of presentation that's not necessarily endo specific, but that's on the science of estrogen, right?
Oh yeah.
Led by one of like the founders of hormone replacement therapy. So it's a tape. I'll let it out of the bag. It's a tape discussion, and I taped it, so I've watched the whole thing. So what's interesting is there are health risks associated with not having any estrogen. And there are also health risks associated with having estrogen. I thought it was a very interesting presentation. I'd love to hear your response.
Yeah.
It's on Friday. It's right before you go, actually.
Oh, great. That'll be perfect. So I think that there has to be a risks and benefits approach, right? So what I would say, even in patients who've had a hysterectomy and who have endometriosis that's been proven, they need to have combination hormone replacement therapy that reduces the risk of recurrence. And also, if they develop symptoms for any reason, we can investigate that further, do imaging studies. Maybe they need surgical management. But this is something that this is a different set of patients. They cannot be grouped with a set of patients who don't have endometriosis. That's the first thing, right? So I would say that everybody also responds differently. And some patients, it's also like the risk factors that they may carry, and use of, if they have a uterus, an intrauterine device and so on. They're all ways of tweaking and tailoring the treatment to that specific patient. In order to do that, we have to know their complete history, their risk factors, and tailor it appropriately so they have the best response. Yes, it's important to have estrogen in menopause for sure, but how do we give it? How do we administer it? That's where the difference lies.
Yeah, so you're Eurogyne, and we are the Endometriosis Summit is getting into the fight for the black box warning on the topical estrogen.
Yeah.
Because the topical estrogen, I wonder if you've looked at that, any of that
Yeah,
research
I have.
in transformation of endometrioma with topical estrogen versus oral estrogen.
So I look at this pretty much all the time because I try to collaborate with my GYN oncologist who's like anti-estrogen altogether. I'm like, no, don't do that, because when we give topical estrogen, especially vaginally, they've shown so many studies that there's not any absorption through the vagina for these patients who actually have malignancies, whether it's breast cancer or uterine cancer, and have had treatment. Their estrogen levels don't change. Their recurrence rates don't change. So as far as the topicals, I would say go for it. But as far as the other, like oral, we need more studies, to be honest. But for those patients, if they have estrogen receptor positivity, then that's not recommended.
Yeah,
But
it's very
topical is definitely the FDA black box warning needs to go away. I'm fully on board with Dr. Rachel Rubin. So yeah, that's where we can talk about that.
we have a whole policy division we're forming to help her in her fight. Also, because when you talk about, like Dr. McHale talked about all those bladder symptoms, those are left because disease is left behind. But the other issue is that the genital urinary syndrome
Symptoms.
type
Yeah.
things that you really need estrogen for. It'll be very interesting. It's a very HRT pro talk to now. I should combine, if I find any room in the program, you're up. So
Okay, I would love to be there.
Yes.
I
So
loved putting this talk together. It was so enlightening even for me, like just to see how there's so much lack of research, and it made me very sad. So I'm like, I'm going to propagate this so that people can be paying attention to this, and when they see postmenopausal patients, they're aware that okay, this is a possibility.
yeah, next year we'll have you maybe expand, but also
Okay.
we'll have you connect with, there's an organization Advancing Health After Hysterectomy. And they're like Yale, Stanford, Dartmouth, all these researchers, and actually they found the connection between lack of estrogen and Alzheimer's. And it'll
Yes.
be
Yes.
very interesting to um, put this presentation with some of like there's some very interesting stuff. Anyway. Okay, so I wanted to ask a question. What do you each find in the post-hysterectomy first and then postmenopausal second? What do you find the challenges are in evaluating the patient?
Okay, so I will start with the post-hysterectomy patient. I think the biggest challenge is that the patient goes to her doctors and describe her symptoms, and the most common response they get, "Oh, you had your uterus out, then we don't know what to do. There is nothing going on. There's no need to kind of complain." They don't validate the patient's symptoms and they study the anatomy and find out the reason of the symptoms. So dismissal, although in all endometriosis patients, dismissal is a big problem, in post-hysterectomy, dismissal is even worse because nobody wants to listen to symptoms after hysterectomy. Then the next challenge, okay, people took the word of the patient seriously. They believed it. They're gonna act on it. Great. The next challenge up is that after doing pelvic surgery, specifically after hysterectomy, there is anatomical changes which makes identification of lesions is very hard. For example, when you do a transvaginal ultrasound, which is the first line of imaging in endometriosis or in pelvic pathology in general, the first thing you look at is the uterus. You kind of scan and you start by looking at the uterus and then using this as your kind of landmark and then go to other structures. But this patient had hysterectomy already, so you are losing your landmark. So your scanning is out of the bat is very hard because your primary landmark is gone. So, the dismissal, then the hard in visualization ultrasound. Also in MRI, it is very, very hard to see the lesions after the deep lesions after hysterectomy because of the same reason. We always, when we think about the anatomy of the pelvis, of the female pelvis, we use the uterus as the landmark and we go off of it to the right, to the left, anterior, posterior, whatever we need to look, but we use it as a landmark. In the surgery part, again, after hysterectomy, there is significant scarring, so you have to take care of the scarring to be able to visualize and find the disease. Number two, the surgical planes are messed up because a lot of patients, a lot of surgeons actually, they open all the pelvic spaces in all the cases. They think it is fun. No, you only dissect the spaces that you need for the case. Because if you open all the spaces, the one is coming after you to kind of treat, you're just giving them very hard time for no reasons. So a lot of dissection, meaning that the planes are gone, so the next surgery is going to be even harder.
I'm off. I'm so sorry. Very, very important. That is always part of the conversation on why excision should be done right the first time if you're going to do it with hysterectomy, because you're making any excisionist's job harder by changing the
100%.
landmarks. Yes. Dr. Mamta, anything to add?
Yeah, I just agree with Dr. Mikhail about the dismissiveness of, especially in patients who are postmenopausal, but even generally, that, patients are dismissed because nobody believes their symptoms, or in menopause, it's like, oh, yeah, well, that's kind of normal menopause. Everybody's got pain, everybody's got sporonia, and that's just the way things are. But in patients who haven't been adequately diagnosed with endometriosis and have like an ovarian mass, which is thought to be an endometrioma, there is a thought process, or there is like acceptance that, okay, it's okay to watch this because they're menopausal. But actually, no, that is not the case, because there is a risk of malignant transformation in these patients, especially if they continue to have the exposure to the estrogen, which may be endogenous. It may be because of obesity. It may be because of tamoxifen. It may be very, not necessarily hormone replacement. It may be phytoestrogens. It could be anything. So there isn't as much care taken of these patients, I feel, as they're aging, and they're like, okay, we'll just see you next year. And by then they would have had the clear cell carcinoma or whatever, and it's like too late. And that's very sad because it's preventable. Why? Just go and remove the endometrioma, avoid all these problems, for the patient, so they can have better health and longevity in their lives, and better quality of lives, not have to go through chemo and debulking and so on, right? So I think that for me is, and also adequate imaging, following the protocols for imaging, making sure that malignancy is excluded, which is hard to do in some of these cancers which don't have a specific ovarian tumor marker. So we rely on radiology for these, essentially distinguishing of what the likelihood of malignancy is, what the likelihood of an endometrioma is, having adequate, backup in case of the malignancy. And adequate follow-up is, again, key, because uh, if endometriosis is not excised from everywhere that it's present, there is a possibility that it's continue to perpetuate and will continue to cause symptoms for the patients. And people always hesitate to go back because, it's like, oh, I just did the surgery and I took out everything I could see. But wait, did you really? That's the question. So for me, it's like, if a patient continues to have symptoms, there is some reason they're having those symptoms. They're not just saying it because of whatever reason. So that warrants investigation and treatment.
Excellent. Okay. We actually have a ton of shares there on Facebook. I watch three different
Oh,
sites all at once. This is a very hot topic. We're gonna have to have you guys.
it is.
Yeah, this is gonna have to be a whole panel next year. Get ready,
Yeah.
Dr. McHale, because this is gonna be a whole thing next year. So we have an interesting question, which you guys may or may not be able to answer, but what is the potential role of mast cell activation syndrome or mast cell proliferation in driving the persistence of endometriosis or progression or recurrence post-hysterectomy?
I think my understanding is that anything that drives inflammation causes there to be a pathway of the prostaglandin E2, and that drives aromatase, and that drives the estrogen. So whatever drives the estrogen will create either de novo or persistence or recurrence of endometriosis lesions. So in order to mitigate that, it's important to keep the mast cells under control. Usually that's done with antihistamines, is to the best of my knowledge, but I'm not the expert in that.
It's
Actually,
interesting. Go ahead, Dr. McHale.
I just want to second Dr. Mamek's opinion about how inflammation plays a significant role in endometriosis recurrence after surgery. And this brings to the concept of that taking care of endometriosis patients in general is a teamwork. It takes a village. So if, for example, if mast cell activation is kind of the thought behind the situation, referring to an immunologist, for example, can be really helpful. This is true in general for endometriosis as a disease, for different subspecialties or different team members because the complexity of endometriosis.
It's interesting because while Dr. McHale was speaking, one of my issues as a physical therapist is that so many of our patients have a hypermobility or a connective tissue disorder, right? And we used to think of like maybe you have mast and that's one thing, and maybe you have POTS and that's another, but now it's really a connective tissue spectrum, right?
Mhm.
So
Yeah.
everybody on that spectrum would have a little bit of POTS or a little bit of mast cell or a little bit of hypermobility, right? Because and that's my thing. If we're going to do a hysterectomy on somebody who already has wonky connective tissue and they already have a lot of trouble balancing their pelvis anyway, we really need to do it right because the damage that you do having to go back in on a patient who's going to have like a huge storm of inflammation occur from the second surgery is really a problem. And then somebody asked about the mast cell, and that's my soapbox for that. Hysterectomy, like in the connective tissue world, they don't love a hysterectomy at all because those are the people at risk for prolapse. So if you're going to do them, they should be done right. That's my soapbox. All right, we are winding out. By the way, it's the first weekend of March 2026, so you two will have to set that aside already. I've already decided.
Yes.
Um, but coming up this weekend is the Endometriosis Summit. We are about 517, as I checked while we were on here, across um,
So,
3 channels. We had to order extra food today, and extra chairs, in fact. So, what are you, Mamta? It's your second one. What are you looking forward to the most about the Endometriosis Summit?
I think for me, the most touching and the most enlightening part was the patient stories, because these are real patients who have real stories and their experiences, and they shared with each other. And for me, looking at that patient perspective and how the system has helped them or not helped them is very, very beneficial, so that I can find ways then to help the patients that were could not be helped or were helped, and what was good about it, those kind of things. But it's also nice to meet up with colleagues and just share experiences, and that's wonderful too. So I'm looking forward to all of it.
Yes, Mamta is discussing. So, by the way, everybody who's going to say, "Oh, you're being disrespectful using first names," at this year's, I don't know if you got your
No,
emails.
no.
At this year's Endometriosis Summit, there is no last name.
Yeah,
Right?
it's
Because the
great.
sociologist said, why do they call me Sally, but they call him Dr. Vidali? And she said, you need to put an end to that. Because if you're going to be
Mhm.
on even footing, if you're going to say patient and doctor are the same in this movement, everybody's on even footing. So I'm not being
Right.
disrespectful. You are presenting Make the Bladder Gladder.
Hmm.
And you're also presenting neuropelviology, which is a big draw for people this year. We're very excited.
Yeah, I'm excited about it. I think it's very important.
Joining us for the first year will be Dr. McHale. Dr. McHale, what are you
Iman.
looking? You've never experienced the endopalooza that is the endometriosis summit. What are you looking forward to the most?
So I'm very excited because this will be my first time, and I think the Endometriosis Summit is very, very unique in the sense of it is bringing patients and doctors together. The concept of we are on the same boat, we are on the same team together. And I keep you kind of emphasizing that the patient has to have a role in the decision making. It is not kind of, oh, you have to do this procedure or you have to do this medication and you have to follow what I'm saying. These days are gone. The patient has to be part of the decision making team. And actually, this is what I was thinking when Dr. Mamek was talking about the estrogen, what to do to give it to the patient, not to give it to the patient, how to risk stratify the estrogen therapy in patients who are known endometriosis patients. And I agree with all what you said, but I just want to add that the patient has to have their input,
Hmm.
being choosing what to do. But you know, Endometriosis Summit is so unique because it brings doctors and physicians together, and this is so important in disease with the complexity of endometriosis. Because I want to be honest, I learned the most about endometriosis from my patients. They are the number one teacher of the disease.
Yes. So I think it's the whole menopause discussion is very important, because I think I'm the oldest one here. But when it hits you, first of all, way more than hot flashes, it's memory loss, it's brain fog, it's general urinary symptoms, it's bloating, it's weight gain, it's insulin issues. I mean, please. So I think the concept of we have to sort of be in that discussion together, but we really need a lot more information as well.
Mm,
Um,
yeah.
I've
And
seen,
research, which
yeah,
is very much lacking.
I've seen, unfortunately, in the past couple weeks, a lot of like absolute statements, like never give people with endometriosis estrogen. Well, there's no nevers ever. There's
Mm,
really, and I think if you're living through it and maybe all your hair is falling out from lack of progesterone, that you're going to make different decisions than maybe somebody else. It's very interesting. Oh, I can't wait. I already can't wait till next year. But if you virtual tickets are still open, our in-person has closed. Funny story, we had to buy new seats. And don't worry, so somebody said, well, all the doctors will sit in the back on Saturday. And I said, no, I said, Momta likes to be up front. That's how I got them to buy the extra seats. I said, Momta likes to be up front. And it's true. It is
It's true.
so
It's true. It's
right.
always true.
So, if you're looking for virtual tickets for the Endometriosis Summit, which comes with a 90-day recording, you can grab that at www.theendometriosissummit.com. Tonight was absolutely fascinating and definitely a small stepping stone for our future together. It was wonderful to have everybody. And that's it. That's it on the season. It's
Thank
a wrap.
you. It's a
Take
wrap.
Thank you
care.
Thank
so
you.
much.
See you
Thank
soon.
you.